This is a bit of practical type of discussion now, how to do it, we are mainly focusing on that. See there, what are the objective of this basic life support or cardiopulmonary resuscitation? How to assess the collapse victim, how to perform chest compression and rescue breathing, and how to place an unconscious breathing victim in the recovery position. So all of these will be learned after this topic. Okay, see there. So this is the different things we are going to learn here: airway management, breathing, and circulation. But according to American Health Association, the sequence is reversed now. We start from C first and then go to A and then B. The breathing is the least important now these days. Okay, the most important is the circulation. And frankly speaking, it has made the job of the person who is doing it very easy. Don't need to think about anything, just press harder and faster on the chest. That's it. No coordination is necessary, nothing. A good type of compression is necessary till the patient is taken to the hospital. Okay, now let's move on. We have already talked about this chain of survival. Okay, the same slide is borrowed here. First is early recognition and call for help. Second, start of early CPR to buy time, of course. Management of defibrillator as quickly as possible and defibrillate the patient to restart the heart, and then provide the post-resuscitation care in a good medical center. This is not a chain of survival. All are important if you want the patient to revive or survive that episode. Now, basic life support means the sequence of procedures which are performed to restore the circulation of oxygenated blood after a sudden pulmonary or cardiac arrest. And this is done by chest compression mainly. Okay, chest compression. And if you have another person who is helping you, then time and again ventilation can also be given. But if you have to focus mainly on the compression, that's the main point here. Now, what to do, sequentially? What's the first thing to do, and what next? Let's talk like that. So first is a approach safety, means make sure whether that place is safe enough for the victim and for yourself as well. Sometimes you may be attacked by some other crowd or some other people when you are about to resuscitate. Now, nobody wants to do resuscitation in that environment. Who will resuscitate if only the danger occurs to your own life there, isn't it? So this is important to know, and we know what type of situation is there. We know quickly enough. Check the response from the patient, shout for help, open airway, check breathing, 30 chest compression, and 2 rescue breath. This is done by one resuscitator. Okay, if 2 resuscitators are there, then we can go 15 chest compression and 2 breath as well. This is a called approach safety. You have to make sure the scene is safe. Okay, and you can approach the victim safely. Okay, what type of bystander are there? Or bystander means what type of people are there nearby? Are they helpful or not? Something like that you need to judge quickly. Second, we check response from the patient. Okay, so how to check response? You have to shake the patient, move the patient there, and shout. Okay, hey, can you listen? Something like that. If you know the person by the name, then you can always call the patient or person by the name. If you do not know the name, you can simply call the patient. Can you hear me? Can you raise your hand? Can you open your eyes? Like that. This is check response. So same thing is written here. Shake shoulders gently. Ask, are you all right? If he or she respond, okay, or not. If the person respond, leave as you find him or her, find out what is wrong, and reassess regularly. Okay, this is called checking the response. Now, another one is shout for help. Remember, during resuscitation, if you are alone, probably you cannot do much. So quickly shout for help. And you need help to call the medical management team also. See that? Okay. After that, another is open airway. Now look at this picture very carefully. Okay. What type of maneuver is this? Yes. What type of maneuver? Look at the picture and tell me.
Head tilt.
Chin lift.
Yes, the two things are happening here. One is head tilt, another is chin lift. See this? Chin is also lifted up. Head tilt and chin lift. Now, this is a very basic thing. So all of us should know how to do it. And this is the excellent way to open the airway, especially if tongue has fallen backward. If I do that, tongue will again comes in its original position and there is no more obstruction to the airway. See this. This is what is happening. Before doing this airway management, like head tilt and chin lift maneuver, there was acute compression of the airway. It is almost blocked here. Okay. After we do that, see this, it has already opened up. Okay. This is an excellent thing to do. And if you have a small, fold of the towel or any cloth, you can keep that fold of the towel or cloth on the shoulder area, so it will really maintain that position. So this is head tilt and chin lift maneuver. Okay, it can be easily done by lay rescuer or non-healthcare rescuer also, who don't have much knowledge, but they can still do it. But one good thing they should know is this procedure helps to open the airway. That much information they should have. Otherwise, why they would do it, isn't it? There is no need for finger sweep unless some solid material is found in the mouth. Sometimes patient is choking there, sometimes there is some other foreign material in the oral cavity or in the pharyngeal area. If you suspect that, then the swift type of finger sweep movement is necessary to remove that. Otherwise, it is not necessary for everyone. Now see this? This is called jaw thrust maneuver along with head tilt and chin lift. Jaw thrust maneuver. Jaw thrust maneuver means you should put your finger on the angle of the mandible and you press there. Okay, press at the angle of the mandible. And if you do that, okay, it will really help the tongue to move forward. This is one extra thing you do. And the more important point I like to highlight here is in case of cervical spine injury, like the fracture you have suspected here, this is the only thing you do in the patient. No head tilt, no chin lift, but only jaw thrust should be done in that situation, because only doing jaw thrust will not move the cervical spine. Now another is a checking of breathing. See this, this is the way to check breathing. Make sure whether the patient is breathing or not. You can take your ear very near to the nose of the patient and quickly check it. This is one way. Another is look at the chest, whether there is rise and fall of the chest or not. And if you are a doctor or medical person, you may have got a stethoscope, you can quickly auscultate it as well. So look, listen, and feel for the normal breathing, and do not mistake gasping breathing for the normal. Gasping is just less than 5 times per minute, or sometimes just 1 to 2 times as well. So do not mistake on that for the normal breathing and don't do anything. Gasping breathing may be stopped anytime. This is just sign of breathing before they stop. Now, what do you do in case of foreign body aspiration or foreign body obstruction? Now, these are the signs of foreign body obstruction of the airway. Now, see there. Okay. If you ask, are you choking? And the patient can still reply, they are not completely hypoxic. If there is a partial type of obstruction or mild obstruction, they can answer yes. They can, shake their head and they can say yes. Okay. Then, we need to do certain maneuver there. And if there are other signs, for example, they can still speak, cough, or breathe in case of milder obstruction. Whereas in severe obstruction, patient even cannot respond. They cannot even speak because there is a severe type of hypoxia. They can just nod their head, or they cannot even do that if they are already unconscious. So it depends on which type of obstruction, if they are milder or severe one. So see this. In case of choking, uh, this is one of the maneuver which is commonly done, giving a good type of back blows to the patient, and we hope the foreign body which is lost there would come out. Okay. Another one is called Heimlich maneuver. So can you tell me, have you heard about Heimlich maneuver? Yes.
Yes, sir.
Yes. Can you explain that?
Yes, sir. It is done for the foreign body obstruction. Sir, if someone is choking, like any foreign body goes inside, so we hold him from backside and make our fist and thumb like close together, and then we put pressure at Ziffy's sternum and push him upward. So maybe it helps.
Very good. Very good. Excellent way he has explained it. Absolutely correct. If you are suspecting choking, and those are the symptoms and signs of choking which we have just discussed, sometimes the person is drinking and eating together. And remember, intake of alcohol makes the gag reflex weaker, so that patient, or the person, I should say, can choke, especially the big piece of meat or big lump of food may be choked inside, and the person will immediately cast the neck. And at the same time, the person starts to cough also. Sometimes there is a total, you know a congestion of the face. Sometimes they may be blue. Sometimes they cannot even speak. It depends on how severe is the obstruction. It is not that difficult to diagnose, but the more important point is how you manage at the site. Okay, he's absolutely right. We do two things. One is this type of back blows which is given, and another is called Heimlich maneuver. Heimlich maneuver is done. Okay, I'll go on the back side of the patient. Okay, and I'll put this fisted hand. Both hands are tightly interlocked together, and that fisted, hand is kept on the epigastric area, and then forcefully, okay, I'll push upward. Okay, forcefully. Then we hope that the foreign body which is lost there would come out. In case of very small baby, you can hold the baby upside down, and you can give a slight thump on the back. This may help. So see this. This exactly is called Heimlich maneuver or abdominal thrusting. Exactly like this. Now let's move further. Let's talk about chest compression. So these are 30 chest compression a person can do if the person is alone. Okay. If there are two person, we can give 15 chest compression, and another person will give the rescue breath after that. Now, how to keep this chest compression? What is the best way? Look at this picture. You have to interlock your finger like this. This is the best way. People may not know how to do it. So from now onwards, or from today onward, if we are about to do chest compression, we should do in this way. Place the heel of one hand in the center of the chest. Okay, means the hand which is below. Place other hand on top of it and interlock the finger. That means your grip there will be very strong now, and compress the chest. And when you compress the chest, remember, don't move from your elbow joint. You move from your shoulder joint. Means extend your whole upper limb. Extend it. And then with a good amount of force, you compress the chest. The rate should be about 100 per minute. Depth should be 4 to 5 centimeter, and there should be equal compression and relaxation. Okay, means the time should be equal for the compression and relaxation. This compression will act like a systolic function of the heart, and this relaxation would act like a diastolic function of the heart. But remember, heart is not working here. That's why you are doing that type of function with the compression. That's the whole idea here. And there should be a good depth, about 4 to 5 centimeter. Now, one of the common thing which is asked by the medical student is, sir, what should we do if we break the rib? Okay. Now you don't worry. You don't worry about fracture of the rib or something like that. Saving the life of the patient is the first thing. Even if that rib is broken, the rib will heal later on. Don't worry. So do it in the good way. Do not only touch it there. Just touching there will not help the patient. You have to push a bit firmly. When possible, change the CPR operator every 2 minutes because it's a tiring type of process. You have to use a lot of energy here, So if possible, change the operator. But it depends how many persons are present there. If you are only one, then you have to do. There is no other way, even if you are tired. Another is called rescue breath, mouth to mouth breathing, a rescue breath. You can exactly see, look at the picture here. Okay, so you have to pinch the nose, okay, cover the whole mouth and then blow inside the mouth. But do not open the, do not keep the nose open, okay, because the air which you have blown will come out from the nose. What's the use of that, right? I want that air to reach the lung. This is the whole idea of mouth to mouth breathing, a rescue breath. So pinch the nose, take a normal breath, place lips over the mouth of the person who is unconscious. Okay, blow until the chest rises. Okay, take about 1 second time and allow chest to fall and repeat the process again. This is the way of rescue breathing. Now, what is the recommendation for the rescue breath? The tidal volume which is necessary is about 5 into 600 ml, and this is the normal tidal volume we have. 500 ml is the normal tidal volume. So if I breathe, if I inspire a little bit more, or forceful type of inspiration, I will take more air inside the lung, and then if I blow forcefully, then I will give that much of air to the patient. That is the point. Respiratory rate is the normal one, okay, which we have we know. So give each breath over 1 second time, and chest compression continuously given at a rate of 100 per minute. So these are the different type of steps which we follow in case of basic life support. Now, if victim starts to breathe, then place the victim in recovery position, and this is known as recovery position. So what is the advantage of keeping the patient or victim in this position? What is the advantage?
So the chances of aspiration is less.
Absolutely correct. The chance of aspiration is less. Okay, and that is the important point here. See this? This person can vomit because of all the effect. The person can vomit. There may be something in the oral cavity. If I put the patient in supine position, high chance of aspiration is there. So if something is there, it may trickle out from the corner of the mouth on the side. So this is called recovery position. Just have a look here. Okay, the lower limb which is below is extended. The lower limb which is on the top is flexed. Okay, and the portion is kept on the lateral position. with one hand supporting the head and another hand is a little bit flexed again. And these are the paddles, okay, paddles which are used for defibrillation in the patient. Now, these are the different things, how to, put the patient in the recovery position. If only one person is there, then it is a bit of challenging thing, but still we can roll the patient and do it. Depends on the size of the patient, actually. Very heavy type of person, more than 100 kg person, difficult to do, especially if she is a female or girl resuscitator, then it is a challenge for them. Yes, they cannot even turn the patient probably, but it is not a difficult thing. So we can put the patient and we can ask for help also if we cannot do it. Now, how long the resuscitation should be continued? Okay, how long? Now, till the qualified help arrives and takes over. That is one. Till the victim starts breathing normally. Second, and the third, I do not completely agreeing this. The rescuer becomes exhausted. Now, saving the life of the patient is more important here. Mm, it is a nonsense thing whether you are exhausted or not. Yes, it would be nice if there is a help for you. If you can switch the hand, it would be better. But if you think this patient can still survive, you don't leave even if you're exhausted. That is not a sign of a good doctor, isn't it? They don't leave the patient right in the middle. I think saying that, oh, I'm too tired, I'm too exhausted, I cannot do any resuscitation. That is not the way. Now, when can I stop CPR? Now, any CPR has a limitation, isn't it? It's like, how long can I do it and when to stop? Now, see there, if victim revives, you don't need to do any more. If a trained help arrives, they will take over. You don't need to do any more. Too exhausted to continue. Just now I talked about this. On safe scene, you don't risk your own health, your own health, or your own life there, and do the resuscitation. For example, bomb blast is going on here and there. They are firing the gun or bullets there. You don't go there and resuscitate the patient. It is your own health, your own life, isn't it, which matters. Physician directed. There is one leader of the resuscitation, especially in the hospital setting, one person who orders or command, and other person will follow whatever the person is saying. So if the person says stop doing CPR anymore, now there's no point continuing it, you stop during that time. Okay. And cardiac arrest for more than 30 minutes, there is no real hope of bringing that heart back to the normal. And half an hour is a long time actually. So we stop doing CPR after that time. Now, why CPR may fail? You have done a very good CPR, okay? You think you have done it well, but still it is not very helpful for the patient. What may be the reason there, isn't it? So there's a bit of a practical problem again, like delay in starting, improper procedures, like forgot to pinch the nose when you are giving a rescue breathing, all the air which you have blown into the patient has come out to the environment again. No advanced cardiac life support follow-up and delay in defibrillation. Yes, without defibrillation, you really cannot help if there's a case of ventricular fibrillation. There are improper technique of defibrillation, means the paddles are not properly kept. And if the patient is having terminal disease or unmanageable disease like massive heart attack, so then also you cannot do much.